Shall we start?
We can start, sir, now.
Yeah. Good evening, everyone. I am Dr. Sanjay Patil, Joint Secretary, IMA CGP Headquarters. I welcome all of you. Today we have our Dean, IMA CGP Headquarters, Dr. Avinash Bondwe, sir. Joint Secretary, Dr. Ambu Rajan. Joint Secretary, Dr. Rekha. And today's faculty, Dr. Jaydev Panchawar. Today is a fourth topic we'll be covering in this series of 8 lectures. So every Friday evening we are meeting. Our speaker is Dr. Jaydev Panchawar. He is MS MCH Neurosurgery and he is well-known neurosurgeon from Pune city. Today he will be covering remaining topic from 27th May, that is neck pain, cervical spondylosis, followed by a very important topic, that is trigeminal neuralgia, severe facial pain. So this will be very useful for our day-to-day practice. So without wasting much time, I request our Dean, Dr. Avinash Bondwe, sir, to address this August gathering, and then Dr. Jaydev will start. Thank you.
Thank you, Dr. Sanjay. All the office bearers of IMA CGP headquarters and our respected faculty, Dr. Jaydev Panchawar, a well-known neurosurgeon. As he's going to talk on the cervical spondylosis. You all know that we have been rather conducting this fourth episode of our neurology series of spine and brain. And you all know, all we primary care physicians look at this cervical spondylosis as pain in neck. Most of the time, either it is overdiagnosed or underdiagnosed. And we see the complications of it, and we have to know much about it. Dr. Panchawar has very lucidly explained all the basics right from the beginning. And I hope that I'm really sure that he will be doing his all the pearls of wisdom in today's speech. Over to you, Dr. Panchawar, sir.
Thank you very much, Dr. Bondwe. Can you hear me properly? Is the sound okay?
Yes, sir.
Yes, sir. Yes, sir. It is fine.
So I'm sharing this screen. You can see the screen clearly. Hello?
Sharing is not coming, sir.
Not yet.
Not yet shared, sir.
Not yet shared?
Yes,
Yeah.
sir.
Okay. And now I think it has got shared.
Yes.
It's okay.
Yes, sir.
We are getting it.
So thank you very much. Let me begin without wasting time. Last time I was supposed to speak about cervical spondylosis, and we spoke about brain tumor symptoms last time. So I am, carrying on with this topic this time. Cervical spondylosis is the most common problem that is seen in general practice, and I think everyone will agree with that. Also, as doctors, because of our posture that our profession requires, many of us suffer from cervical spondylosis. And as Dr. Bondwe rightly said, sometimes it is overdiagnosed also. I will tell you how it is overdiagnosed, how it is underdiagnosed. In both ways it works actually. So being a common problem, it can be very easily misdiagnosed. And that is why we are going to look at this closely today. So, cervical collar, we see many people on roads moving around with cervical collars. And the reason for that cervical collar many a times is vertigo and not cervical spondylosis. And many people think that cervical spondylosis causes vertigo. It is a most deeply ingrained misconception that one can see today. And I will speak about it as we go ahead. So our spine is very unique in the sense that human spine is the only spine that is, while moving around, it is continuously in the vertical or erect posture position. All other spines are horizontal, but the cervical spine is either oblique or vertical. As a joke, we used to ask our juniors in neurosurgery who used to join that the first question to you is, how many vertebrae are there in giraffe's neck? So they used to think that it is a very clever question, difficult question, but the answer is giraffe also has only 7 cervical vertebrae. And only that these vertebrae, as you can see here, they are extremely large. Extremely large. One vertebra is, nearly half a foot long, as you can see here. So giraffe, this long neck has also got 7 cervical vertebrae. This is just a useful and interesting information before going to the other aspects of cervical spondylosis. So spondylos in Greek means vertebra, as we all know, and isis or cis means inflammation. So spondylosis actually means, in simple words, it is a disease of the vertebral column, nothing more. But what spondylosis has come to be known today is very different. So how does it develop? We saw in lumbar spine how spondylotic process develops. So similar process develops in the cervical spine. This is a picture from one of the most remarkable studies carried out on human cadavers with thin sections, actual anatomical sections like MRI, and absolutely stunning and beautiful images. And you can see very clearly that these are the cervical vertebrae. The white shadows are the discs in between the cervical vertebrae. And behind, in the spinal canal, there is a spinal cord. You can also see a thin spinal canal, the central canal of the spinal cord here, through which the CSF flows, and this is the epidural space. And this is the subdural space where the CSF is located. So the first thing that happens in spondylotic process is reduction in the height of the disc. This happens because of repeated use. Also, some people are prone to it, definitely genetically, but it happens because of repeated use, wrong posture. Disc, as you all know, is a structure which is not, which does not have direct blood supply. The nutrition supply of the disc comes from the surrounding vertebrae. There is migration of fluid across the end plate into the disc, and that's how the disc gets nourished. So intervertebral disc does not have blood supply. So as the age advances and as awkward posturing and awkward movements increase in frequency due to our day-to-day life challenges and our professions, the disc height starts reducing. So as the disc height starts reducing, the body gets the signal that there is some instability at this area. So the body's response is to send calcium in this area to stabilize anything that is unstable. So you will see that at any place in the body, if there is instability, for example, if there is a fracture of a long bone and there is instability, what body will immediately do is first it will contract the muscles surrounding that fracture so that the fracture fragments do not move, and they are given solid support by muscular contraction. And second thing it will do, though much slowly, is to send calcium in that area to bridge the gap that has developed. So even in spinal column, body thinks that there is instability because there is change in the height of the disc, and it starts sending calcium, and the calcium starts getting deposited around the disc circumferentially. So when it gets deposited behind the disc, the spinal canal gets encroached, and if it is very severe, then the spinal cord starts getting compressed. If the calcium spicules start compressing on the exiting nerves, then you will get compression on individual nerve root, which is going in the upper extremity. So if the spondylotic process crosses or increases beyond limit, then there is a compression of the nervous elements, and you start getting serious symptoms of spondylosis. And these are the symptoms which one should not miss in general practice, because many a times people suffering from these symptoms think that these symptoms are because of something else, like B12 deficiency, or because of diabetes, diabetic neuropathy, and so many other diagnoses are attached to it, and they think it is because of something else. So these are the symptoms that we will see in detail, especially from the point of view of general practice. It is my duty as a neurosurgeon to make you aware of these early symptoms. Now, this is a drawing of the same section, and as you can see here, this is the intervertebral foramen, and these are the nerve root coming out. This is a nerve root that is coming out. One is motor, one is sensory, and they will soon join here. So here it is almost joined. See, this is the nerve root. And as you can see, the posterior end of the disc comes very near to the nerve root. It forms the anterior boundary of the intervertebral foramen. And if the bone spicule forms here, then the nerve starts getting compressed. So this is a different view, beautiful cut in anatomical study. So as you can see here, this is a fairly normal height of the disc here seen between the vertebral bodies. And here, the height of the disc is reduced and new bone or osteophytes are forming. So these are beak-like projections. These are the osteophytes as we see in the X-rays of the patients with spondylosis. You compare this level, that is, this is C2, C3, C3, C4. Now C3, C4 disc height is all right. There are no osteophytes here. Here you can see these spicules. These are the osteophytes. These are actually deposition of calcium crystals, almost forming a new bone here. You can again see a big osteophyte here, and there is one big osteophyte behind. So if the spinal canal gets encroached on by these osteophytes, then the spinal cord, as I said, can get compressed. So this is a very beautiful picture drawing actually in a patient with spondylosis with the neck in extension. You can see that this is extended neck, and this is the spinal cord, and you can see these calcium spicules or the osteophytes compressing the spinal cord here, and the ligamentum flavum, the ligament which is behind the cord, folding inside and compressing the cord, and the cord getting compressed. Very beautiful drawing, very self-explanatory. And this drawing shows how in spondylosis, the diameter of the cervical spinal canal reduces. It is usually 13 to 16 millimeters, and here it has become 11 millimeters. The space for the spinal cord has reduced, and any neck movements at this point of time will repeatedly compress the spinal cord, giving rise to progressive myelopathy. So, are some people prone to develop cervical spondylosis? The answer to this is yes. Actually, there are some genetic studies which prove that the osteophyte formation in some people is more than in other people. Also, last time, as I told you last time, in some people, the spinal canal diameter is congenitally small. And in these people, if the osteophytes are formed, then even with small osteophytes, these people will start getting neurological symptoms. But are some people genetically more prone to develop it? The answer is definitely yes. There are some people who are genetically more prone. So early symptoms of spondylosis is, as I said, as the body detects that there is change in the disc height, the body will put the neck muscles in spasm, and there will be pain associated with this spasm. So neck pain is the earliest symptom of spondylosis. Now this neck pain, one has to remember, is not always restricted to the neck. This is something one has to remember, because the pain of cervical spondylosis can spread right in between the scapulae. It can spread into the shoulder, and it can also spread in the occipital region. Not only that, sometimes it can spread in the temporal region. So a facet joint osteophyte somewhere here can cause pain in the temporal region. So this is very well known thing, and the reason for that is the trigeminal ganglion comes down into the spinal cord, and that's why these areas are overlapped as far as the pain referral is concerned. So neck pain is not only actual neck pain, it is also shoulder pain, it is trapezial pain, it is occipital pain, and sometimes the pain above the ears, that is in the temporal, posterior temporal region and the occipital region. So this pain at times is very, very severe. If there is muscle spasm repeatedly happening, then the muscle attachment points become trigger points, and they become extremely sensitive, and these people can get absolutely debilitating pain with cervical spondylosis. So this stiffness and neck pain, as I said, is the earliest symptom. So these are the common tender points also in cervical spondylosis. This is the area which usually people tell you when they have cervical spondylotic pain, and they are having severe stiffness and pain in this area. Of course, there are some other reasons also at times for this pain. So one has to take a good history and do good examination also. As in the case of low back, when is the neck pain serious? So there are three important things that one has to remember. So if the neck pain is spreading in the hand, that is in the arm or forearm or the hand, fingers, it is radiating, one has to take it seriously. It can be a radiculopathy. If there is myelopathy, now symptoms of myelopathy, cervical myelopathy, can be initially hidden, and that is why I am going to tell you in detail about these symptoms, the symptoms of myelopathy. Usually the symptoms of radiation or radiculopathy are very easy to detect. One thing that you have to remember is that shoulder pain, that is shoulder joint pain, and neck pain can sometimes coexist. Okay, now the reason for that is cervical cord compression or root compression causes weakness in the muscles of the shoulder joint. So it starts at times, not always, but at times it starts with the cervical cord and root compression. The shoulder muscles become weak, and the shoulder loses its stability, and the shoulder joint degeneration starts. So the shoulder pain can be secondary. Like we always say, before knee replacement is done, one has to check the lumbar spine, right? Last time I told you that lumbar spine, if there is a compression of a nerve supplying the muscles around the knee joint, then if you do the knee replacement before lumbar spine surgery, it will not give you good results because the joint will not have good stability because the muscles are not strong. Similarly, one should not treat shoulder without looking at the neck, because the muscles of the shoulder are supplied by the neck spinal cord. Now, the radiculopathy can be in different fingers, in different parts, depending on which root is getting compressed. So I will come to that afterwards. But again, for radiculopathy and myelopathy, the other red flags are recent trauma, the pain, neck pain, if it awakens you at night, if it causes weight loss, it is associated with fever, if it is rapidly and unexpectedly increasing in severity, and if there is a history of cancer in the patient who is having neck pain, or there is a history of some immunocompromised situation in his or her life. So these are the red flags that one has to remember. So as I was telling you, the myth of giddiness has been attached to cervical spondylosis for a long time, and the reason for that is one of the old reports of a small osteophyte which was reported protruding into the vertebral artery canal. And in that particular case, actually, the giddiness was being caused by cervical spondylosis. But it is so rare that till today, I have not seen in my practice giddiness because of cervical spondylotic compression. Now, in those cases where it happens, why does it happen? It happens because there is a foramen transversarium here through which the vertebral artery passes. And if a large osteophyte starts compressing on the vertebral artery, then in a particular position of the neck, the person feels giddy because the blood supply to brainstem can reduce. But it is so rare that you can literally forget it. Just know the theory, but you can forget it. It's so rare. But many people think that the giddiness or vertigo is because of cervical spondylosis, and that's why they have been prescribed collar. Actually, the collar is prescribed for another reason. The collar is prescribed because collar avoids sudden movements of the neck. And as we all know, the giddiness which is related to labyrinth, which is inside the ear, occurs because of sudden neck movement. So the collar at least prevents this movement, and it reduces the incidence of giddiness because of that reason. It is not because of cervical spondylosis. Many people in my OPD tell me, sir, I have spondylosis. I have been wearing collar for so many years. And when I do the MRI is normal. So this is something one has to remember. This is again a very beautiful slide from the study that I was telling you. This is a cross section from a cadaver, and you can see a formation of bone. This is a bone which is formed. This is an osteophyte which is pressing on the spinal cord. This is a cross section of the spinal cord, and the spinal cord is getting compressed here. Also, if you look at the outgoing root, this is the outgoing root, and this is the osteophyte which is protruding into the foramen, and it is pressing on the outgoing root. And this actually could be the reason behind a radiculopathy. So these are actual cadaveric studies to show you what exactly happens inside the body. So as I was telling you, the radiculopathy pain normally starts in the neck. Neck pain precedes it usually, and then it spreads into the shoulder, and then it goes in the arm, and then it spreads in the forearm, and then finally goes in the one of the fingers. So as one can see, the C5 radiculopathy is usually restricted to the arm. It is restricted to the arm and the shoulder, sometimes up to the biceps. C6 radiculopathy goes right into the thumb and index finger. C7 radiculopathy in middle and ring finger, and C8 radiculopathy goes in the little finger. So this is a generalization, because at times the dermatomes are overlapped and you cannot really pinpoint the root that is compressed. Also, one has to remember that some people have the brachial plexus which is prefixed, that is one level up. In those cases, C4-5 level disc, which should have compressed C5 root, actually compresses C6 root because it is shifted up. So these are other things that one has to remember. So this is a generalization that C6 radiculopathy goes in the thumb and the index finger. So radiculopathy is a severe pain which goes down. Usually cervical radiculopathy is associated with tingling and numbness, and also weakness at times. If there is weakness, one has to really act fast and reduce the compression surgically. Otherwise, it can become permanent. If there is only pain, initial conservative treatment can be given a serious trial, and this includes analgesics and rest, and in some cases traction. Traction is, in my opinion, not very useful in all cases. In some cases, they say that pain increases with traction. So one has to actually individualize depending on the patient's experience of the pain. But one has to remember that if the radiculopathy is becoming very severe, and or there is weakness in the muscle, or is a chronic radiculopathy with wasting of the muscles, one has to act and reduce the pressure on that particular nerve root. So some similar pains which mimic radiculopathy are shoulder joint pain, myofascial pain, insertion pain, visceral pain. As we all know that a diaphragmatic pain is referred to the tip of the shoulder of that side. Also the cardiac pain at times is referred to the shoulder. So one has to remember these possibilities. Though usually if you take proper history, it is very clear when the pain is visceral and when it is related to the nerve. In all other pains, like referred pains, there isn't any neurological symptom associated. For example, you don't get heaviness, you don't get tingling and numbness, you don't get weakness, you get only pain. And the pain has that typical visceral referred category of dull and boring nature. So if you take proper history, it is not difficult to differentiate, but one has to remember the possibilities that there have been instances of shoulder pain which were actually investigated for neck for a long time, but the pain was actually coming from something else, something like gallbladder or subdiaphragmatic abscess or something like that. There have been instances like that, so it can happen. So one has to remember that. Also, last time I had shown you a case who was investigated for a long time for cervical spondylosis. That lady used to have a repeated neck pain, and along with that occipital pain with photophobia and vomiting. And in the end, when she came to our unit, we realized she has neck stiffness, and we did her CT scan of brain, which showed subarachnoid hemorrhage. And I showed you the clip maybe last lecture. And we clipped that aneurysm, which was low, that is posterior fossa aneurysm, low down in cranium. And that's why it was giving rise to neck pain. So one has to remember other causes of neck pain. Neck pain is a very, very common and severe symptom. So as I said, are there any pointers that it is a nerve pain? So yes, there are. There can be tingling and paresthesia. The pain is usually neck movement related. There is old history of chronic neck pain before radiculopathy. It is dermatomal in distribution, distributes in a specific pattern, and there can be root distribution weakness associated. So these are the pointers. Also, the examination will show you, wasting or depressed reflexes, etc. But It has been my experience that in most spondylotic spinal problems, a good history, a very good history, a good observation, and simple, very simple examination should clinch the diagnosis. So history is the key in this, and remembering the possibilities is another important thing that one has to remember. Now, this is the example of formation of large osteophyte. It is shown by two black arrows here. So this is osteophyte, okay? This black thing is a spinal cord. This is a CT myelogram. And on this side, you see open intervertebral foramen through which the root is going out. Here, because of the osteophyte, this foramen is closed. And this person was having right-sided severe radiculopathy. And this had to be resected. This osteophyte had to be resected, as you can see here, anteriorly. And it was reconstructed with a bone graft. And this canal is now open on both the sides. So this is a surgical treatment of severe radiculopathy. Now, cervical myelopathy is a very important topic, and because I see so many times that the symptoms are missed, not only by general practitioners, but by many other doctors from many other branches. So this particular person, was going to a physician for a long time with a history of, weakness in the hands and tingling in the hands and also tingling in the lower limbs. This person around 50 years of age was also a diabetic, and the physician was treating this patient for diabetes. And naturally, if one is treating someone for diabetes and such symptoms come up, then naturally one assumes that it is because of the diabetic neuropathy that it is happening. And he used to report progress in the symptoms every time, but they were neglected. And afterwards, he started saying that I'm not able to walk properly, I'm losing balance. Incidentally, he was also an alcoholic. So this person thought it is alcoholic gait because the loss of balance in cervical myelopathy doesn't look much different from the drunken or alcoholic gait. It looks like that. Some cervical myelopathy patients have told me that my office colleagues or my friends, they are teasing me for last 2-3 months that I'm drinking too much or something like that. Now, it is very similar to alcoholic gait. And so this diagnosis was missed for a long time. In the end, this guy had heaviness in both the lower limbs, could barely walk. And that's when he saw me, and you can see there is a severe compression at 3-4 and 4-5 level. The spinal cord is pinched here. You can see this dark black shadow here. These are the osteophytes because bones look black on MRI. One has to remember that because we are used to seeing bones as white shadows on X-rays or CT scan. On MRI, the bone looks black, and you see the compression at 2 levels. What you can also see here is a hyperintensity inside the spinal cord, and it is because of this repeated compression that this edema has developed and also myelomalacia has developed. So what is the meaning of myelomalacia? Now, this is very important to understand. When there is chronic repetitive compression episodes on spinal cord because of the compromise in the blood supply and because of the repetitive mechanical hammering of the cord, the anterior horn cells of the spinal cord or the neurons of the spinal cord slowly die. Okay, and as you all know, the nervous tissue, once it dies, it doesn't regenerate. So these cells are lost permanently. And that is why in cervical spondylosis, one has to make early diagnosis. And if there is worsening, there has to be early intervention. You have to err on the side of surgical intervention rather than conservatism. Like one can err on conservative treatment in lumbar spine. In cervical spine, it should be the other way around. So one has to very clearly remember that, because once the neurons are lost, they are lost. You can especially see here, the spinal cord has become thin. Why? Because the neurons are lost from here. So even if I decompress this now, these cells are not going to come back. So whatever dysfunction is there because of pressure or whatever is yet to happen, I can stop. But I cannot reverse this, what has already happened. Now, this patient could have easily been diagnosed 2 or 3 years ago if the symptoms were heard properly and examination was done properly. And maybe a lot of function we could have preserved, but eventually we operated. About 40 to 50% of his problems got reversed, luckily. But the cells which are lost, of course, no one can, return those cells. And this is after surgery. We resected the central parts of the body and expanded the canal and reconstructed with this cage and screws and plate, titanium, of course. And with this kind of construct, we can allow the person to mobilize immediately. Maybe after 8 to 10 hours after surgery, they are allowed to walk. This person was not able to walk at that time, but with support he started walking, and now after many months he is 40 to 50% better. But his improvement has plateaued, it has stabilized, it is not happening. Now it has plateaued, so there is no progressive improvement now. This is another example. Early diagnosis, relatively, there is edema inside the cord, 3-level compression. But this one was picked early and decompressed, and nearly 90 to 95% of his function is back to normal. So this is the importance of catching this early. Again, one has to remember this diagram. This in extension, if there is spondylotic myelopathy, the cord gets compressed because the ligaments get folded inside, and there is repeated pinching of the cord, like someone is actually hammering on the cord with a hammer. So why one has to remember this is that many people think that if I have spondylosis, neck spondylosis, I will do a lot of exercises. I will go to the laughter club, I will go to some gymnasium and do a lot of neck movements. They think it is beneficial. Now, actually it is the contrary. Contrary in the sense that if they do too many and repetitive neck movements, their cord is going to get repeatedly hammered. And of course, there will be progressive neuronal loss. So over-enthusiastic physiotherapy and exercise in the presence of cord compression is extremely dangerous, extremely dangerous. In lumbar spine, I will say that it is not much useful, but in here, it is extremely dangerous. Not only not useful, it is dangerous. So after decompression, if it is required, then after decompression, one can do proper physiotherapy. This is another example of severe, very severe cord compression. This is the spinal cord, and you can see CSF shadow. This is a white CSF shadow. And here there is extreme cord compression. And these are the cord compression one has to be really wary about. So the symptoms start with loss of balance while walking, tingling in the hands, and these hands progressively lose muscle mass. They are known as what is called as useless hand. It is called as useless hand syndrome because of loss of the anterior horn cell. Okay, this can also happen in some neurological disorders also, like amyotrophic lateral sclerosis or motor neuron disease. One can lose anterior horn cells. So, but in motor neuron disease, there are no sensory symptoms. Remember that. In cervical spondylosis, you will get motor and sensory symptoms. Now, sudden flash-like symptoms or sudden flash going down the back starting from the neck and into the legs. It's called as hermit sign. This happens especially on movement of the neck. This is a indicator towards compression or a disease inside the cervical cord. Hermit sign is also seen in multiple sclerosis. So there need not be frank compression, but there has to be a cervical cord pathology for the hermit sign to occur. Now, slipping of chappals is another thing that one has to ask for sometimes. The diabetics think that it is because of diabetes again, but slipping of chappals can be with the person's awareness or without his or her awareness. With the awareness means that the sensory function is intact, but he is not able to hold on the chappals with the grip of the foot. Okay, so that is more likely to be motor neuron disease in origin. But without realizing, slipping of chappals is very classical of cervical spondylotic myelopathy. Weakness in hands and heaviness in legs. Then progressively these people need support for walking. They need chair, and then they become bedbound, and then even urinary symptoms start. So these things should not happen in the modern times, and I think neurosurgical intervention is extremely important, and it should be done in time. So loss of balance while walking, is very much like a drunken man's gait. You can see the hand muscle wasting here. These muscles can waste in severe cervical myelopathies. So if symptoms are properly diagnosed, further things can be prevented. X-ray, CT scan, MRI, and if required, if in doubt, then EMG NCV is done. And as we all know, X-rays show only the bones. They do not show anything that is neurological, that is spinal cord or nerves, etc. No ligaments are seen. So X-rays are only very broad and general indicators. One has to have MRI in the modern era. So in treatment, of course, the decompression can be done from behind and from front. So it is a neurosurgical decision when to go from the front and when to go from behind. And sometimes if there is severe compression, we have to go from the front and fix and then also decompress from behind. So all sorts of permutation combinations are possible. These are difficult surgical decisions which can be taken in neurosurgical OPD. And this is how the spine is approached anteriorly. Just lateral to the esophagus, medial to the carotid artery, there is a straight corridor to the cervical spine. And this is how the discectomy is done. And then finally we do the fixation. So when I was doing my MCH, I wrote a thesis on cervical spondylotic myelopathy and radiculopathy, especially about the outcome analysis when operated anteriorly or posteriorly. So it is one of our very, very important subjects that we are, interested in, and we have a lot of work in. This is another example, literally bead-like appearance of compression, severe spinal cord compression. And here you can see severe spinal cord compression, and after after laminectomy, how the cord is decompressed. However, there is a white shadow inside the cord. That is a sequelae of the long-standing compression that I cannot reverse even after removing the compression from behind. This is an example of anterior compression on the cord pinch, severe pinch on the cord. Again, severe pinch on the cord here, you can see single level, but severe pinch. This we had to go anteriorly and resect and then fix this with a spacer and screws and plate. So these are the, of course, titanium plates now available. They are extremely useful, very light. They have tremendous strength in them. They have locking screws. So technologically, we are supported from all the sides, but clinically, we have to be aware and diagnose these things, really early and in time. So this is now, before finishing, I'll show you, this is one of the severest case that we saw. Compression starting from 3-4 level right up to 3, 4, 4, 5, 5, 6, 6, 7, and 71 also to some extent. So this patient needed anterior surgery and posterior surgery both. But this patient is walking today. Let me tell you, this guy is around 65 years now. We operated on him about 7 years back. This person is walking. He came to us on wheelchair, but this person is walking. The sad part is, if he was diagnosed even earlier, we could have prevented so many other things. But anyway, I hope this sends the right message. And with this case, I think I will stop here. Next time we will talk about, again, a very important topic, that is pain, facial pain and pain in the gums. It is also called as suicide disease, trigeminal neuralgia, and we run the National Center for Trigeminal Neuralgia. So I think I will share this experience with you. I am sure it will be helpful for you, because it will come on the background of nearly 17 or 18 years of long experience. As Dr. Bonway would know, that we are committed to this subject along with hemifacial spasms. So these are the subjects: the cervical spondylosis, trigeminal neuralgia, hemifacial spasms, subjects very close to our heart, and we are working in a very focused manner on them. So next time I will speak about trigeminal neuralgia. This time now we will stop, and if there are 1 or 2 questions, we can take.
Yeah. Sir, I would like to ask you one very important question. As if you remember, I myself had this type of problem, cervical spondylosis, few years back, and you treated me. That time, rather, we discussed that usually it does not require any medical treatment in young age, and it gets recovered within 6 weeks. So I would like to ask you, for the benefit of all our primary care physicians who are attending, that what are the symptoms or what are the things when you have to refer the patient to a neurosurgeon?
If it is restricted to neck pain and the neck pain is tolerable, then there is no need for immediate referral at all. I mean, then if one starts referring, then neurosurgical OPD will be full of such patients only. There's so many.
No, we never refer, sir. But
so many
there are some symptoms. Yeah.
So many patients have neck pain. So, but the neck pain, as I told you, if there are red flags, that's why I showed you red flags. If there is a radiation, if there is myelopathy symptoms, that is loss of power, wasting, loss of balance, slipping of chappal. See, these are all serious problems. If they're associated with neck pain, then you have to take the neck pain seriously. It is not only neck pain, but neck pain associated with these symptoms. Also, if there is radiculopathy, which is not going away, rapidly, or you must have seen patients with severe radiculopathy where they just cannot, move their hand. They come like this, literally, and they literally beg you to do something. So it is a very severe radiculopathy. So these kind of patients need referral. But if a person gets pain sometimes, and with over-the-counter analgesics and massage and these things, it gets relieved, then there is no need for referral immediately.
And what are the rather indications when you rather decide it needs surgical listening that our people should know? You already explained it, but if you can point out again.
Which is progressing, myelopathy, if there is cord compression and there are symptoms of cord compression, I personally do not waste too much time if there are symptoms which are progressing, because these people are advised variously. As you know, they go to physiotherapists and they say, we will give you exercises, don't worry, you will recover. Then again, 1 or 2 months go, they lose some more neurons, because this worsening is very slow, So person doesn't understand that he's worsening till it dawns on him that now he is not able to button his shirt. Okay, he is not able to actually break chapati or break or mix rice easily. He is not able to hold on his chappals. The chappals are slipping. So when it dawns on him, then he realizes what is happening for such a long time. So when I see such symptoms progressing and MRI showing frank compression, I at least advise them that you need surgery because things can be prevented if done in time. It is true that spinal cases sometimes can go in different way, as I told you in lumbar spine. There are some patients in whom you advise surgery, you believe that he requires surgery, but he comes after 1 year and says, I'm fine. Okay. So but it is rare, it is not a norm. Can it happen? It can happen. But it will happen once in 100 patients. In cervical spine, you should not even take that chance because if the cervical symptoms worsen and neurons are lost, they do not come back. That is why you have to err on intervention. This is my philosophy, especially if cervical spondylosis is progressive.
Sir, one last question. What are the post-operative complications of surgical procedures in cervical spondylosis?
See, the potential complications are innumerable, but with the microscope and cervical endoscope, along with the titanium constructs, the rate of complication has drastically gone down. Drastically. I mean, complication is a rarity now in cervical spine. That it was not a case some years back because people did not have good quality implants. They had to put bone grafts. They had to rely on the stability of the bone grafts. They were, of course, good surgeons, but technologically, they didn't have that much support during that time. Having said this, cervical spine infection, blood clots, epidural blood clots, uh, or the implants coming out, especially in elderly people, if correct implants are not used, then implants coming out is one of the possibilities that can happen in cervical spine. Damage to the nerve or the spinal cord is an extremely rare thing to happen, but potential is always there. Potential is always there. One has to remember that in any surgery, no surgery is without risk. Like, there is a saying in Marathi, "Akhud shingi bahudupti gai naste." That means a cow who has a very short horns and who gives lot of milk doesn't exist. So this is one of the sayings in Marathi. Similarly, there is no surgery without risk.
Thank you, sir. Sanjay.
All right. Next time we'll meet again.
Sure. Please, Sanjay, conclude the session.
Yeah. Thank you, Dr. Jaydev, for your excellent presentation. And we have our Vice Dean also, Dr. Janmay Jha. Sir, would you like to say something?
Good evening to everybody, respected National President sir, the HAG sir, and our Dean Dr. Avinash sir, Secretary CGP Dr. Siabransu sir, and five Joint Secretaries, and the Speaker of the evening, Dr. Jaydev. Today is the fifth topic in the series, and everything has already been discussed and presented by Dr. Jaydev vividly. Thank you, Dr. Jaydev, for your very excellent and informative talk. Everybody will be benefited by your talk. Thank you again. I am thankful to our National President also for giving me the opportunity. First of all, I extend my sincere thanks to National President and Secretary and our Dean, Dr. Avinash Pandey, and Dr. C. Abramsu, Honorary Secretary, IMA CGP, for attending this CME. which gives us an encouragement, and their valuable inputs will help us a lot. I am also thankful to Dr. R. Amburejan sir for successfully coordinating this meeting, along with other 5 Joint Secretary, Dr. Rekha, Dr. Jan Sharma, Dr. Satyajit Bora, and Dr. Sanjay Dattarai, Dr. Prabhat Kumar, Dr. and other team members of IMA CGP for their kind active cooperation for the success of this CME. Lastly, I extend my heartfelt thanks to everyone for their help and cooperation, and to all the delegates for attending and make this event successful. Thank you all. Thank you. Long live IMA.
Thank you.
Yes,
We
sir.
conclude here.
Thank you, everyone. Thank you.
Thank you, sir. Thank you, sir. Thank you, Bharat.
Thank you.
We'll meet next week.
Next week.
Yes.
Chalo, meet.
Okay, sir. Avinash sir, कैसे हैं sir? Okay, Ambulanjan sir.
Thank you,
Sir,
everyone.